Hi, everyone. My name is Nina Resetkova. You're joining me in my office here at Boston IVF. I'm a fertility physician here. I've been at Boston IVF for over 10 years. And I'm going to be giving a talk today on LGBTQ plus fertility. Start off with a little bit of intro slides and then open it up for Q&A, which will actually be the bulk of the session today. So welcome, everyone. You're actually joining me in my office in downtown Boston, close to Post Office Square. This is where I see patients. And I also have a special interest in LGBTQ plus family building, both from a research standpoint and a clinical standpoint. So I'll be able to share some of that with you today. All right, we'll jump on in. Happy Pride Month, everyone. Thanks for joining us today. A little bit about me. I'm originally from Toronto, Canada. I went to college in Montreal, and then I went out to the Wild West in Texas for my medical training and did my OBGYN training at the Johns Hopkins Hospital in Baltimore, Maryland, and then came to Boston IVF to do my fellowship training. And then I've since stayed on here both as a clinician, also as an educator at the Beth Israel Deaconess Hospital in Harvard Medical School. And here are all our affiliations. A little bit about your process. Some of you may already be in the process of fertility testing or treatment. Maybe you're already established with us or another clinic. Just a few things. If you're looking for a good treatment center, we really acknowledge that your needs in selecting a treatment center are for respect, recognition of your relationship status, and really availability of and experience with procedures, making sure that we have all available technology and the right treatments to best take care of you and help you build your family. And so really what you should be looking for is a partner in the process of family building. So what is kind of the first step when you're thinking about initiating your family building journey? How does that get started? Well, the first thing is you want to get set up with a reproductive specialist like Boston IVF. So the way that we do it is you call into our call center and then you schedule an appointment with a reproductive specialist who will go through your medical history, if you have a partner, your partner's medical history, and then make a plan for any sort of fertility testing that would be recommended. At that appointment, it's a very comprehensive appointment, and there could be a review of potential treatment options, some timelines for treatment, some of which can be lengthy depending on which pathway you're going down. And then we, within our team structure, also have financial coordinators who can help navigate you through some of the costs and coverage with your insurance as well. So we are a full spectrum fertility care center. So we can help you with a fertility evaluation, which could just be a kind of a fertility checkup, see where you're starting off from, give you a better understanding of your ovarian reserve or fertility potential. So we can do testing for you. We can also do natural cycle monitoring to help you understand your natural menstrual cycles if you're assigned female at birth. We can do insemination or IUI. We do egg freezing, IVF treatment. We also do reciprocal IVF, or otherwise called partner-assisted reproduction, which I'll touch on a little bit today. And I know we have some questions about that from the group as well. And we also do egg donation and surrogacy services through our third-party reproduction team. So I wanted to kind of guide you through some of the very basic fertility workup for folks who are assigned female at birth, just to give you a better understanding of what you might expect. There are, of course, variations of a fertility workup. I'm just going to kind of talk through the basics to give you a foundation. And if you have any more specific questions about that, feel free to add it into our chat box so I can answer those for you specifically. Okay, so to get a better understanding of the reproductive anatomy, we do an ultrasound. The ultrasound is a pelvic ultrasound. It can be done either vaginally, that's an internal ultrasound, or abdominally if you're not comfortable with a vaginal scan. Basically, what we're looking at is the uterus, the size of the uterus, whether there's any abnormal structures in the uterus like fibroids or polyps that can distort the anatomy. We're also looking at the ovaries and quantifying the number of available follicles or potential eggs that are on the ovary. So that is something that the basic ultrasound can give us good information about. We're also able to tell if the ovaries are accessible, and then if there's any challenges to potentially having an egg retrieval or any sort of reproductive procedure. So it gives us a lot of good information. And the fertility-focused ultrasound is a little different than a basic ultrasound, which typically does not quantify the eggs. We also order some blood work, which is quite comprehensive and can get a lot of information with a fertility workup, including even some testing that can help you understand your general health better and can help guide some recommendations for your general health. So that workup consists of ovarian reserve testing. Specifically, we're testing a hormone called the AMH, or anti-Müllerian hormone. And that test is a predictor of how many eggs are remaining on your ovaries. We can compare that against where you are in relationship to other people in your age group. And we can also correlate that with potential success rate of fertility treatment like egg freezing and IVF treatment, and give you a better sense of how many treatment cycles may be necessary to achieve your goals. So it gives us some good preliminary information. We can also do some labs that can help you assess your health for pregnancy, like prenatal labs and STD testing. And for those folks who are contemplating use of donor sperm, we always recommend a genetic testing panel to help you better understand if you have any genetic risks and if you would want to screen donors based on those genetic risks. And as well, we also recommend CMV testing to help you select a sperm donor. For many who are interested in conceiving through donor insemination, and also for folks experiencing infertility in heterosexual couples, we would likely recommend a form of a uterine cavity evaluation and a fallopian tube check. So one form of this, and probably the most common form of this test, is called the HSG. It's a hysterosalpingogram. And what you can see here is this dye that looks white under X-ray imaging. So there's some contrast dye there that's highlighting the inside structures of the uterus and fallopian tubes. So you can see the uterus is a roughly upside down triangular shape. And this is a normal uterus. And you can see the dye nicely spilling through the right fallopian tube and then ultimately through the left fallopian tube as well. So you can confirm that the fallopian tubes are open with this study. Also, the study helps us to understand if the uterus structure is normal and whether there's any lesions on the inside of the uterus that could affect the success rates with fertility treatment or pregnancy. This test can also identify abnormal uterine structure configuration. So it's a very, very comprehensive study and likely will be recommended for many folks assigned female at birth. So people always ask kind of why do a fertility checkup before starting treatment? And I think a lot of this applies to folks who are thinking about initiating treatments at home, potentially, with a known donor or home insemination, kind of why come to a fertility clinic to do a fertility checkup? And, there's a lot of helpful information that you're going to get from a consultation with a fertility specialist, and the testing can help indicate different risks that are present for you and help increase chances of success for you. And if you live in Massachusetts, most commercial insurances will cover the cost of a fertility workup as well. So, that would be important to evaluate for you, as well as what are the costs and, is it reasonable? But for most people with commercial insurance, it is covered. At the fertility checkup, we'll also review any medications with you, understand if there's any risks to pregnancy, any modifications that you would need to make before doing treatment or before conceiving. We can also help you manage any underlying health conditions, work with your primary care doctor to optimize those. We also do preconception counseling. And, we can also, very importantly, address any underlying gynecologic issues that can impact your chances of success. So, I've had patients previously with polycystic ovarian syndrome who were doing home inseminations who didn't really have a great sense of when they were ovulating. And that's always disappointing, to be using donor sperm, which can be very expensive, and not have a good chance of success with that treatment. So for patients with PCOS, the fertility clinic is very, very valuable in optimizing your chances of success with treatment, endometriosis, uterine fibroids as well. So we would address all of these findings and make a specific plan for you for your family building journey. And then, of course, we want to optimize your health prior to treatment. So really working healthy habits, moving towards a healthy weight, regular exercise, and then reducing toxic habits, things like minimizing or excluding alcohol, avoiding recreational drug use during treatment, and particularly in pregnancy, stopping smoking, and then getting you started on prenatal vitamins as well. So what kind of treatment options are available for folks who are in same-sex female relationships? Well, we'll talk a little bit through insemination, that's IUI. We'll talk through a little bit of fertility preservation, which is a great option, and increasingly we see some coverage for it through insurance providers as well. IVF and reciprocal IVF are also great options, and in some cases, egg donation and surrogacy may be considered as well. We won't touch so much on egg donation and surrogacy today in our topics because we're talking a little bit more about the donor sperm pathway. But if you have any questions specific to you, feel free to share them in the chat or follow up with our marketing team if you have any more specific questions that are a little bit more personal in nature. So we're going to start by talking a little bit about artificial insemination. So this would be insemination with the use of donor sperm. Most of our patients purchase donor sperm through a donor sperm bank, and we do have links to 4 sperm banks on our website. So if you want to get a little bit more information about some of the more commonly used sperm banks, you can find them through our website and then access the links. They will also provide you with a little bit of insight about cost of donor sperm treatment. Donor sperm is fairly expensive, so we definitely want to be judicious about the use and really optimizing the chance of success with treatments. Donor insemination is fairly straightforward. We're really wanting to place the sperm inside your uterus, so inside the anatomy around the time that the egg is releasing. And so there's multiple ways to time that. You can time it using a natural cycle, or you can kind of hasten or optimize the natural cycle by using medications to help develop 1, 2, maybe 3 eggs, and then correct the timing of the menstrual cycle if you have irregular periods. Putting in the sperm, you can see here there's a little vial of washed sperm that's in place in a very slender catheter, and then the catheter is inserted through the cervix, again, around the time of ovulation, and the sperm is inserted into the lower portion of the uterus. For most people, it's a very quick procedure, so under 5 minutes to complete, pretty well tolerated, very minimal discomfort. Some people have a little bit of cramping with the insertion, but it's a very low volume of fluid, so for the most part, well tolerated. And then you can go back to your regular activities, with the exception of you don't want to be drinking alcohol, you want to be avoiding any sort of environmental toxins and exposures, and kind of go on, as if you have a high chance of pregnancy success. So avoiding the things that you would want to avoid in pregnancy as well. For folks who are starting this journey under age 35, so for our best prognosis patients, generally we recommend doing somewhere between 3 to 6 rounds of insemination, assuming that your anatomy is normal, in that you have normal fallopian tubes. For folks who are starting this journey older, greater than 35, typically less treatment cycles are recommended because the success rate per cycle is not quite as high. And we want to make sure that you still have the opportunity to do IVF treatment when you have a good egg count and good egg quality. So typically we recommend completing a smaller number of treatment cycles before making the transition to IVF treatment. And, lastly, insemination can be done with the use of medications, or it can be done in the setting of a natural cycle. Multiple different ways to do inseminations. IVF is a more advanced strategy. IVF stands for in vitro fertilization. And IVF is a much more successful treatment than IUI, or intrauterine insemination, but it's also much more involved. IVF involves about 8 to 12 days of daily injections. There's more monitoring with Bloodwork and Ultrasound at our centers. And then IVF requires a surgery to harvest your eggs. And that surgery is done with anesthesia. So it requires you to take a full day, maybe a couple of days off work, depending on what is your yield or your egg count. But with IVF, our success rates are simply much higher than they are with IUI because we're getting a lot more eggs. So for an average 35-year-old, the typical egg yields are somewhere between 10 to 15 eggs. And in some cases, they can be lower or higher depending on the ovarian reserve, but that will typically yield in the production of an embryo or even multiple embryos, and genetic testing may be an option with IVF treatment as well. sort of two ways to go about IVF. You can do a fresh transfer, meaning that when you create the embryos, the best quality embryo can be transferred into your uterus or potentially your partner's uterus. Or all the embryos can be frozen. So that would be a cryo-wall, a freeze-all cycle. In those cases, we can hold on to the embryos for many years, and the chances of success is still going to be very good. We do have robotic storage systems at our center, and the embryos hold up very well, even over prolonged periods. So I did want to touch on reciprocal IVF. There's lots of different ways that reciprocal IVF is described. Sometimes it's called co-IVF, sometimes it's called partner-assisted reproduction. But basically, the process intimately involves two partners in producing the embryo for pregnancy, and then the other partner carrying the pregnancy to term. And so essentially, this is a good option for folks where one partner is really wanting to be the genetic parent, but isn't comfortable carrying the pregnancy, or maybe has some medical contraindications to carrying the pregnancy, or really just an elective family building decision. And again, we are seeing more fertility benefits that do kind of offer or may cover this in some form. But for the most part, for most of our patients, this is still out of pocket, especially if it's for elective indications, not medically indicated. So one partner undergoes the egg retrieval portion, where eggs are extracted after the shots are taken for 8 to 12 days. And then the egg is fertilized and an embryo is created. And then the other partner undergoes preparation of the uterus to receive that embryo and then carries the pregnancy. And it's important to know that this can be coordinated. So it can actually be coordinated real time. We can do this once the embryo is created, it can go back in the uterus of the other partner. If it's a little cumbersome, it's a little bit more tricky, but it can be done. So most patients choose to do it over 2 separate treatment cycles. It's a little bit easier to do that way. And it's a really beautiful opportunity for both partners to be intimately involved in the process of family building. And the success rates are also very good. They typically are a little bit better than our general IVF success rates. I also wanted to talk through a couple of options for transgender individuals, particularly trans men, looking at fertility preservation. There's multiple options for folks who are assigned female at birth and are transmasculine. You can freeze your eggs. You can freeze ovarian tissue. You could choose to undergo donor insemination or insemination with a partner's sperm, potentially, or reciprocal IVF, where the transmasculine person would undergo an egg retrieval, embryos would be created, and their cisgender partner would carry the pregnancy. So lots of options. Some specifics for those who are joining in who may have some fears about accessing fertility care. We really strive to create like a very open and inclusive environment. There is a lot of insurance coverage for gender affirming care, also with Massachusetts health plans. So you may be pleasantly surprised that you might actually have some coverage for treatment. It is also possible to do treatment without inducing menses or a period. That can be very uncomfortable for some folks. So we are able to accomplish that fairly high rate of success as well. And it's also possible to do transabdominal ultrasounds during your treatment. So if that's something that would make you feel more comfortable, just share that with your provider. It's something we can definitely accommodate. And then, a lot of this comes down to good rapport with your medical provider as well, making sure that you feel comfortable and cared for. We did a large study published now a number of years ago, about 5 years ago, in one of our major journals, Fertility and Sterility, looking at outcomes for trans male patients undergoing egg freezing or embryo creation for fertility preservation. And this is a pretty big study at the time. It was one of the first and largest studies to kind of outline a descriptive approach and have some comparison to our cisgender population. And we found that the egg yield was actually very good. In fact, slightly better for transmasculine individuals freezing their eggs or creating embryos. And when they had been exposed to testosterone before and came off testosterone for a period of time, it was not predictive of the outcome. So the egg quality did not appear to be worse when they had been on testosterone previously. And then both the egg freezing and the pregnancy outcomes, mostly for for their partners carrying pregnancy were very, very strong. And most patients really just needed one, in some cases, 2 treatment cycles to have an excellent outcome. So that was a study we're very proud of. And we continue to do work in this area as well. So I'll conclude here in terms of my slides. This is our phone number if you want to schedule a consult. I'm sure the team will share that with you as well. I'm going to stop my screen share and then just take some questions. It looks like we have a few questions coming in already. So plenty of time. Don't be shy if you want to add in some questions as well. I do also have some that came in ahead of this too. So we can try to get through those one at a time. All right. Q&A. Okay, here we go. So we have our first question, 2 hopeful mothers here. If me and my partner are interested in carrying a pregnancy, how should we choose who goes first? So, there's so many things that can guide this or help you navigate this. I would say probably one of the first criteria would be your age, because age really impacts fertility treatment success rates. And so you want to think about your age now, but also what is the age where you're going to be when you're anticipating your final pregnancy, and kind of build that into the master plan and be very communicative and open about that with your fertility provider to make sure that there's still time for you to kind of complete your family building goals. Because it can take a little while to get plugged in for treatment, do testing, and then ultimately, complete a successful treatment journey. So you want to make sure that you have good time available to expand your family as well. The next step would, of course, be fertility testing, and I would encourage both of you to have testing, even if one partner is younger by a number of years than the other partner. It's still really important for both of you to have testing done simultaneously to help identify if there's any risks of premature menopause or premature depletion of your eggs. Also identify if there's any anatomic challenges that you'll want to kind of factor into your planning. And then also to evaluate both of your benefits, particularly if you're on different insurances, to see, one of the benefits kind of better aligns with your goals. So, we can help you navigate all those things, but the testing results will also inform your decision making. And in some cases, what we'll also recommend is that if one partner is choosing to carry a pregnancy first and get started, the other partner may consider some fertility preservation, potentially freezing eggs or embryos for the future, to help again with the later stages of family building. And sometimes you're in an age where having the first pregnancy may not be that challenging if your testing results look good. But if you're forecasting delaying the second pregnancy, maybe for 3 to 5 years in some cases, there may be some recommendations for either freezing eggs or embryos to help you achieve those goals. Because your present eggs are always going to be higher quality than your future eggs. Not only do you have more of them now, but their quality is much better. So the number of treatment cycles that are needed to get to a good outcome is going to be less. Great question. What is the process for purchasing donor sperm? So most people choose to work with a donor sperm bank. So as I mentioned on our website, we actually have links to 4 major sperm banks. So you can start by navigating that. The website's really great. It's really easy to use. And so take a look there. And I would encourage you to take a look at, 1 or 2 at least to kind of get a better sense of what their offerings are, what the prices are per vial. Sometimes they run promotions or specials where if you buy a certain number of vials, you may get a discount. So, look into that and then see how many vials are recommended by your care provider as well to help you achieve your goals so that you can, try to purchase ahead, because some of the challenging things can arise when you don't have enough sperm to help you achieve your family building goals. Then you might have to pick certain strategies for treatment like IVF if you're running out of sperm. So you want to make sure that you're really planning for all the pregnancies and having sufficient sperm present at that time. As far as actually buying it, so that's done with the sperm bank. All the transactions are with the sperm bank, but we do help facilitate the process of approving the donor. Approving means reviewing the genetics of the donor versus your own genetics, the person who's going to be the genetic parent in your relationship, and confirming that there's no overlapping genetic carrier conditions that could result in offspring that are born with a genetic mutation. And so we'll review the donor genetics, compare them against yours, make sure that it's a good match. And then we complete a form for the sperm bank that essentially allows them or permits them to send sperm to our facility. So that's a form that we fill out for you, and then you can go ahead and set up a ship date for the sperm to be shipped over to our center. Next person asks, female couple here, do I need infertility testing still? And yeah, we touched on that with the slide deck as well. I still recommend that you both have testing done as well, particularly if you're both thinking about participating in the process, or even if you just want a better sense of, would this be possible for you in the future? Fertility testing is great. Even if you're considering doing at-home insemination, I would still recommend a fertility workup. And of course, if you're thinking about doing things at home, you can talk to your OBGYN about that too. But it's very reasonable to get a fertility workup at a fertility clinic, understand if there's any risks or any requirements for you to do treatment in a fertility clinic. Keep that in mind as well for insurance reasons. A lot of times they don't recognize at-home inseminations. And so by the time you present to the fertility clinic, even if you've done a few treatment cycles already at home, it may not be acknowledged or recognized by the insurance company. So that's also another reason to consider clinic-based treatment over home-based treatment, and the success rates are higher as well. So yes, I would recommend fertility testing to give you a better understanding of your fertility potential. Anonymous asks, how can I improve my egg quality and fertility? So egg quality is mostly impacted by your age. So doing fertility treatment, doing fertility testing at earlier ages is going to help you maximize your success rates and your fertility potential. But there are also other things that you can do to help maximize your chances of success and your general health, which can impact your egg health as well. That's taking good care of yourself, minimizing toxins, alcohol, drug use, etc., not smoking. We know that smokers have an earlier age at menopause by probably about 2 years in general. So avoiding those toxic habits can help. You can also take some very basic kind of fertility supplements, like a prenatal vitamin. Some people also recommend coenzyme Q10 or CoQ10, which has some studies that suggest it may help with egg quality. But a lot of this comes down to genetics, but can be helped by really good diet and lifestyle habits. And then, if you're thinking about delaying fertility, the other thing I would also recommend for you is just to get a fertility checkup to really understand what are your chances now and how might those change, looking at the future to see if fertility preservation could be helpful for you. The next person asks, I've had 4 embryo transfers with no success. What could be the reason? I'm sorry to hear that. It's tough when we experience recurrent implantation failure. So no success after multiple transfers. This is such a, specific, probably very specific to you, but certain things that can impact success rates are age and chromosomes. So I don't know if the embryos were genetically tested or not, but that can be a reason that embryo transfers fail, is if they're chromosomally abnormal embryos. Other reasons that embryo transfers can be unsuccessful come down to the uterus. If there's uterine factors like fibroids or lesions inside the uterine cavity. So really good fertility evaluation for you would include looking inside your uterine cavity and confirming that there's no lesions there, no inflammation, no infection, etc. And then, looking at the embryos, the quality score of the embryos, the laboratory, the grading of the embryos, all those things are going to be important in devising a plan for your next steps. And then talk to your doctor about, whether there's any alternative protocols you could consider, how you tolerated the medication. So all of that will be important in determining a plan for next steps. But in many cases, when we see recurrent implantation failure, very reasonable to consider genetic testing of embryos to help understand that at least the embryo is not the issue, that the embryos is good quality, and then really working on optimizing the protocol to transfer that embryo. The next question is, with medicated IUI, intrauterine insemination? How do you time starting the medications? So timing the medication start really depends on if you're having regular periods or if you're not having regular periods. So if you are somebody who doesn't get periods, you have an ovulatory condition, potentially polycystic ovarian syndrome, PCOS, then you can start the treatment as long as you've had testing that confirms that you're not pregnant or you haven't ovulated recently. So that's a good way to do it. Sometimes it's important to reset your uterine lining and have you have a bleed before you start. So then you would be starting with the traditional timing, which is cycle day 1 of your period or with a period. So there's sort of multiple different ways to do it, but a lot of times we use a testing panel to help figure out where you are in your cycle, make sure that it's safe to do so. For IUIs, usually we're using either oral medications or injections. And for the most part, the oral medications are taken from cycle day 3 through cycle day 7, sometimes cycle day 5 to cycle day 9. So it kind of depends. If you're taking any injections, they usually start around the same time, but maybe continue longer. Okay, next question. Can you talk about sperm donors in a typical process? And how long is typical for sperm donors wait list? That's a great question. I think this would probably be best directed to the sperm bank that you're working with and the donor because it can quite vary. I've had patients who have tried to wait for a sibling match. They want to use the same sperm donor for a sibling, and they are on a wait list for a long period of time. Sometimes they're actually connecting with parents who've also used that donor on social channels, Facebook, etc., to see if anybody has any additional vials for that donor. So that those are other mechanisms of getting more sperm. The other format, that I think is important to talk about is directed donor sperm as well. Some folks are working with somebody that they know who's donating sperm, or they're working with an agency that's connecting you with a sperm donor. And those processes can take a really long time. So I would say most of the time we're seeing timelines or delays of about 6 to 8 months if you're working with a directed sperm donor. It takes some time to do the testing and quarantine process for that donor. Whereas if you're working with a sperm donor from a traditional sperm bank, you can typically get the match and get the sperm shipped within a 1 to 2 month turnaround. It's a little bit quicker. So kind of depends on what your specific case is. But set out the level of importance for sibling match for yourself if that's high priority. Get on the social channels to make sure that you're connected with other parents or individuals who've received that sperm or used that sperm before. And then talk with the sperm bank to see if they have some insight for you on how long it might take from prior patients' experiences. The next person asks, is there a recommended body mass index range when pursuing fertility treatments? So there is an optimal range of healthy weight, but for some people, reaching a BMI of 18 to 25, which is considered the ideal BMI, is very challenging or can feel impossible. So working towards a goal for you based on your historic weight, and when knowing where you typically are when you're incorporating healthy habits is really important. Things that can help you in achieving that goal are working with a nutritionist, potentially working with a trainer, or doing an exercise program, and then working with your doctor or medical team to establish what is the healthy weight for you. As far as what we can do in terms of the IVF side, in our center, we are an outpatient surgical center, so we can only accommodate patients up to a BMI of 45 in our outpatient surgical center. Beyond that, we would recommend that you work with a hospital-based fertility program if your BMI is higher than that. But there's no specific cutoff for insemination treatments. So definitely working with your doctor to identify what that healthy weight is for you and working towards that. In many cases, you can actually do that as you're pursuing some fertility evaluation and fertility treatment. So I wouldn't recommend that you delay setting up an appointment to talk about treatment. I would recommend that you do the testing and then figure out what all options are available for you, and then try to work on healthy habits alongside. Where do I see patients? I see patients in downtown Boston, and yes, we are an inclusive office. We help all patients. I do have a very large LGBTQ plus patient population. So if I can help, let me know. A wonderful team here in the downtown Boston office. But our whole center, Boston IVF, has diversity training, LGBTQ plus training. So we try to create a very favorable experience for you and your needs. But yeah, happy to help. And I think that there's a little bit more in the link here as well as about how to find me. And if you want to schedule an appointment, happy to accommodate. Usually I book out about a month or two. So it's not too bad if you're looking for an initial appointment. Somebody asks, should we be completely sober while pursuing fertility treatments? And does it matter? So most data shows us that very light alcohol use, that would equate to typically a few drinks per week, a few meaning like 2 or 3, does not adversely or at least significantly adversely affect fertility treatment outcomes. However, when you are in your IVF treatment cycle or egg freezing, it's best not to consume alcohol. And certainly at the time that you're doing an embryo transfer with intent for pregnancy, it is important to avoid alcohol as well. For folks who are drinking more heavily or regularly, so that's 1 drink per day or more, there are adverse effects on cycle outcomes and pregnancy success rates. So when you're working towards optimizing your health for pregnancy, be it natural pregnancy, insemination, home insemination, or insemination in the clinic, IVF treatment, if you have some optimization to do there, I suggest you start a couple months ahead of initiating treatment so that you're really in a better place and your prognosis will be improved as well if you're making those changes. If you do have a male partner and the male partner is heavily drinking, that can impact success rates as well. Similarly for donors, if donors are donating sperm to you and if they have heavy drinking habits, it will be best to reduce that. For cisgender men, or men assigned male at birth, if they're drinking more than 2 drinks per day, on average, it can lower testosterone, it can lower sperm count, and it can impact fertility success rates as well. So there's room to optimize there also. Next question is, my wife and I are thinking about using a known donor. Any benefits or cautions we should be aware of? Well, the known donor situation is that, it takes longer. So that's the first thing that I want you to be aware of. And be careful, because with the known donors, you want to make sure that you really have a good understanding of any of the risks involved with use of known donor sperm. If there's any health risks, lifestyle risks, with the use of that known donor. So make sure you're really screening known donors carefully. There's a lot of additional evaluation, social work evaluations recommended to make sure that they're donating for the right reasons. They're not donating excessively. And then if it's somebody that you know personally, you just want to make sure that you have a really forthcoming conversation about their intent to participate, in child rearing, how present they want to be. And then, of course, you'll need to work with an attorney, a reproductive attorney. If you want some recommendations for names, we can help you with that as well. But, just make sure that things are sort of really clean at the beginning to make sure that you both have the same set expectations as far as involvement in the future, and the attorney can also help with that. Some of the pros when you're using a directed donor is you can usually get more sperm, more vials of sperm, because guys who have good sperm counts, can typically do one deposit and it can be parsed out across multiple vials. So the cost per vial is going to be cheaper, but the upfront costs are very expensive. So compared to just buying 1 or 2 vials from a donor sperm bank, you're going to be paying a lot more for that directed donor. So, it's good for folks who envision having multiple children with the use of that donor, envision doing insemination treatment, where you're going to need to use a large amount of sperm to have a high chance of pregnancy. So definitely, this is something to talk through with your fertility provider as well, the pros and cons. But the time and the upfront cost tend to be setbacks. The advantages being, more sperm, and then obviously the potential to have that relationship with that individual going forward. I think we just have a couple of questions left. So we're doing well on time. If you want to sneak one in before the end, we should be able to fit it in. So we have when should an HSG be done? And actually, it's a great question. Should we do an HSG upfront or after a number of failed IUIs? So this is a great question, and this is really comes down to your comfort level with procedures. If you feel that pelvic examinations are really uncomfortable for you, and you would want to do the most to sort of avoid, any sort of pelvic examination, or it's sort of more intrusive or invasive procedures, and you don't have any high risk history, you don't have any history of STDs, pelvic scarring, endometriosis, major abdominal or pelvic surgeries, it is reasonable, in my opinion, to do a couple rounds of insemination without doing the HSG up front. The drawback is that if you do the HSG at that point and you identify any abnormalities that have reduced your chances of success, you might regret it, because an HSG is a fairly simple, kind of like quick procedure, and it gives you a lot of information, kind of as I shared with you with the slides. And sperm is really expensive. So if you've used up a lot of vials of sperm along the way, you may have some degree of regret. You say, gosh, I didn't really have a good chance of success with these IUIs. So my recommendation in general is that you do it upfront along with the other fertility testing, so we have as much information as possible. It can also increase the patency of the tubes, kind of opens up the fallopian tubes a little bit. Chances of success with fertility treatment, particularly IUIs, are improved. So there's benefit. But if you're really, if you're really scared, or if you've had some bad experiences in the past and you want to hold off and you don't have any high risk, characteristics for fallopian tube disease, you can think about deferring for maybe 2 or 3 IUIs and then do it at that point. The next question asks, for medicated IUI, will the medications be prescribed in advance so you have it at home, or will you only be prescribed after checking labs and imaging with your cycle? It's a great question. So it is this kind of a different workflow, depending on the way that you and your provider have kind of set it up. Sometimes there's some testing that's done ahead of the cycle to make sure that you're good to start up. And sometimes you have a plan that helps you kind of move forward with multiple cycles. So it just depends on how that's been laid out. Definitely talk about that with your provider to make sure that you're on the same page and you understand, how that's going to work for your cycle. We do need the sperm to be present at the beginning of the cycle. So that's one important thing to note, is the sperm have to be present in order to be able to start up your treatment cycle, because we don't want to have you go through, ordering expensive medications, monitoring injections, and then not be able to do the IUI. So that is an important part of our process. So perfect. So I think we've gone through all these questions. I just have one question here, 2 questions here that I wanted to address from the pre questions that I received. So somebody asks, can you do a transabdominal ultrasound instead of a transvaginal one? The answer is yes. So if you're uncomfortable with transvaginal ultrasounds, in most cases, we can see a good amount of information with transabdominal ultrasound. In some cases, we can't see everything. And so if you have that strong preference, you can kind of talk about the pros and cons with your doc and kind of see what makes sense for you. But transabdominal is reasonable for most patients. At least it will give us some good preliminary information. And then does Boston IVF do anything with surrogates? Yes, we do have a third-party reproduction team. So, for example, if you're in a male-male couple and you want to have a pregnancy through donor eggs and surrogacy, you would be working with that special team. There's a lot of regulatory oversight from the Food and Drug Administration for anybody working with donor eggs, donor sperm, and then also working with gestational surrogate, somebody who carries the pregnancy. So we have a special team that's devoted to that. You would still be working with your clinician, so your doctor would still remain your doctor, but you work with a specialized team to help navigate you through some of those logistical details through that process. And if you have any additional questions, feel free to reach out. We can provide you more information on our third-party reproduction services. All right, everyone. Well, it's been great to chat with you today. Let me know if I can help with anything down the line with your family building, and happy Pride Month. I'll see you next time.